Good evening, everyone. My name is Ray Hu. I am an interventional cardiology fellow at Cedars-Sinai in LA and former president of National APAMSA from 2016 to 2018. 7 years ago, I started this bootcamp series because I noticed that there's a wealth of resources dedicated to acing of med school clerkships and step exams, but it was much more difficult to find teaching material dedicated to this window where you transition into sub-internship or internship. And I'm really pleased at how much energy and growth we've seen through the years, considering that everyone here is a volunteer. I hope that in the next 2 hours, we'll be able to give you some tangible clinical pearls as well. It is an honor to have three stellar residents and fellows today, Dr. Leena Yin from Swedish Cherry Hill, Dr. Ryan Fang from UW Seattle, Dr. Suzanna Tom from Temple Chestnut, to give today's teaching on core topics in family medicine. Family medicine is the backbone of healthcare. In family medicine, you're managing diverse medical conditions, building long-term relationships with patients and their families, offering continuity of care that spans generations. And you will see that reflected in today's topics as well. I'll hand it over to our National Board student leaders, Katrina and Annie, to orient you to today's format.
Hi, everyone. Thank you so much for being here. We're really excited to have all of you and our amazing residents as well. And thank you, Lily, for that great introduction. Let me share my screen to just give some introductory slides and talk about some general, like how this session will go. Okay, so once again, welcome to our Family Medicine Boot Camp this year. We have amazing residents Ryan, Suzanna, and Leena with us here today who will be presenting on some common topics within the field. And we just had our introduction remarks. This is part of a series of some of our larger boot camp series. So we have had a few already, and then we have some upcoming ones throughout the remainder of May, including an EKG session, an emergency medicine session, and a radiology session. If you guys are interested in joining, those will also be happening on those following dates. For participation throughout the session, just be mindful that while the resident or attending is speaking, there also will be others trying to answer questions in the chat box. And so we welcome your participation. So please raise your hand if you would like to speak or ask a question. And if you are, please say your name, school, and year of training. Otherwise, if you're not speaking, make sure to kind of have like sound off and on do not disturb and no sounds like as other people are presenting. I will hand it over to our residents to introduce themselves, starting with Ryan.
Hi, everyone. My name is Ryan Fang. I use they, them pronouns. I did family medicine residency from 2021 to 2024, and I'm currently a fellow in hospice and palliative care at University of Washington in Seattle. I have special interests in HIV, LGBTQ health, palliative care, obviously, and then obstetrics. And yeah, nice to meet you all.
Hi, I'm Suzanna Tom. I'm a first year currently at Temple Chestnut Hill. So I'll be finishing my first year, starting my second year in July. I have like a wide variety of interests, and so we'll see how that eventually translates into my job. But I do think I'm gonna do either a 1-year Geri fellowship or like combined Geri Palliative fellowship after. But yeah, nice to meet everyone.
Hi, everyone. My name is Leena. I am a current third year at Swedish Cherry Hill Family Medicine up in Seattle. So I'll be graduating in over a month. No one's counting the days. My passions include immigrant and refugee health, particularly focused around our unhappy community, adolescent sexual and reproductive health, and health justice. And I love boba, and I have 2 cats who may or may not come say hi at some point. So really excited to be here, y'all.
Thank you so much, Ryan, Suzanna, and Leena for being here. I will stop sharing now and hand it over to you guys so you can begin the presentation.
Yeah, so just to start, Rui actually gave a lovely introduction, but I will talk a little bit about sort of like what family medicine is, because it's I mean, it's everything, right? It's like, that's basically what we do. We do full spectrum care from birth to death, including, prenatal care, labor and delivery, reproductive and sexual health, inpatient medicine. We also do a lot of hands-on, not only delivering babies, but also office procedures. And our field is uniquely poised to be at the forefront of several other domains that I feel like have just been emerging over the past decade or so, including like addiction and palliative, which Ryan is part of, as well as queer health, adolescent health, geriatric health, integrative health, pain medicine, and then of course, like addressing the care needs where they're most dire, including in immigrant, refugee, and rural care. We will not be talking about all of this today because that's, impossible and 3 years of residency. But instead, we will be talking about some of the fundamentals of family medicine, hopefully that you can take away and screenshot, because a lot of this is just like a bunch of information. And so our hope is that you can take these references and revisit them throughout your residency, or at the very least be familiar and be like, oh yeah, I did hear that somewhere. Let me like look that up again, because that's really what our field is about. So today we'll be covering screening, preventative care, common family medicine bread and butter topics, including hypertension, hyperlipidemia, and type 2 diabetes, as well as we'll run through a couple of common primary care complaints that I feel like you don't get a ton of teaching on in medical school, which is very like internal medicine focused. We'll talk about some like birth to death, so prenatal care, pediatrics, reproductive and sexual health, HIV care. We'll talk about geriatrics and palliative care, as per our two wonderful current fellow and maybe future fellow in advanced care planning. And then we'll talk about some of these special topics: addiction medicine, gender affirming care, musculoskeletal care, as well as sports medicine is a fellowship that you can get into through family medicine. So, and obviously something we see in the office a lot. And yeah, again, please ask questions in the chat and we will moderate as appropriate. So now I'll turn it over to Suzanna.
So we'll start by going over screening guidelines. I want it to be obviously give credit where credit's due. I'm borrowing a lot of slides from Dr. Justin Chin, who presented last year. Because why reinvent the wheel? So this first slide is just going over the USPSTF. As you guys may already know, there's the A and B guidelines, which are like what we consider as gold standard. C is like, you can go like either way, and then D is like don't. Just remember D for don't. I though is actually like where a majority of like the statements are currently, just because I think there's like a lack of evidence that to like prove that they're truly helpful. But some of these things that are things that we are already implementing, probably in your clinic, my clinic. And so if you feel that if you go and look it up and you find something as an I or a C, it's best to look and see if there is a different organization that has like more specific guidelines. Like if you see to the left, or to the right, excuse me, we've like listed some other folks that you might want to reference if you're attending or someone asks about like, oh, where are you getting your information from? But just keep in mind that the USPSTF guidelines are usually what's going to be tested on in terms of like your formal testing, like STEP and your complex. So these are the A and B guidelines. There's, I think Justin mentioned there's like over 55. You are not going to like memorize all of them. I think that's really hard to do. Maybe like once you're attending with like decades under your belt, then you'll know. But definitely like look them up. And a lot of times if you are using Epic or hopefully the other EMR systems have also implemented it, but it'll like pop up as like health maintenance and care gaps that you can refer to in your like outpatient clinic visits. And there's really no big change when I compared like 2024 versus 2025. Okay. So in terms of the C recommendations, I believe there are like in total 11 of them, but these are 3 that we highlighted to just because like they come up more often. And so the first one is your aspirin as primary ASCVD prevention. You can see the symbols that are on top. The AHA and the ACC have like more specific guidelines on what to do about aspirin. the multimodal fall intervention geriatrics. As you may guess, the American Geriatric Society has their own recommendations, and then with the PSA screening, the AUA, or the American Urological Association, has their own set of guidelines. So moving on, this is to highlight the American Society for Colposcopy and Cervical Pathology. They have their own app, which the QR code links to, but I will be honest, I did not test the QR code to see if it still works, but you can find it easily. I think the app itself costs like $10, which as a resident, hopefully you can get like reimbursed with your like program funding. But I feel like this is a very, and there is a web calculator that you can look up to. It's just like, it's app like app.accp.org, and you can like enter in information to like find out what is appropriate in terms of pap smear screening. So you can see that on this next slide where you know, you like put in the age and like the situation, and then they like spit out recommendations that I think is very helpful, because again, it can change a lot depending on age and like prior results and things like that. Okay. We're moving on to shots. I realized I should have kept some slides from last year to intro, but this is like an overview of the pediatric shot or vaccine schedule. There is a shots app that is like very helpful too. If you don't have that already downloaded, you can download that. And they also will show a diagram kind of like this. I believe this is from like the CDC itself, but basically it tells you like when something is recommended based on like the age. And then this next slide is just the adult one. And the only thing I'll mention here specifically is that pretty recently they changed the guidelines for the pneumonia vaccine, the PCV, and that hasn't been like updated in these tables yet. And so that is now lowered to age like 50 for those who don't have history of vaccination, which usually applies to most like middle age and higher adults. Because I think it came out in like 1990s or something. I think like that. Okay. Okay, cool. So now we're gonna go into the big three as we foreshadowed. We're gonna start with hypertension. And so defining hypertension, yeah, depending on like who you ask, there's different cutoffs. You can see the JNC 8, or the JNC stands for the Joint National Commission. The 8 is like the version of their guidelines. So this is the most recent one. This is from 2013, whereas the ACC, the AHA, they came out with updated guidance in 2017. So you can see how their cutoff for hypertension varies a little bit. But also if you look up the AAFP guidelines, that one, I think I saw from 2022 is the most recent one. And that also still keeps the 140/90 as like the cutoff for your stage 1 hypertension. And in general, I just look at the AFP for everything since we're family medicine. Cool. So, oh, and then sorry, on the right side, that's just like a table that kind of goes over how they explain or categorize your pediatric hypertension, but it's a little more complicated just because it takes into account like their weight and height and like percentiles. So that's just best to look it up if you're in that situation. Okay, so in terms of like treating hypertension, we'll first go over this. Well, we're not gonna go over it, but I'm just showing this guideline from the JNC 8. And as you like take a look, you might see that there's different recommendations based off of like your race. But there are like new studies that show that maybe that's not very helpful. Specifically, I found that there was a study that was published in 2022, which showed that while more PCPs are prescribing based on race, like giving your thiazides and your calcium channel blockers to our Black patients, but they're still having like worse outcomes in terms of like uncontrolled hypertension after 2 years of treatment. And so I think there's more evidence coming out now that race-based medicine, at least in terms of like hypertension and probably other things, like aren't the way to go. Next is treating hypertension from the AHA and ACC guidelines. They don't give specific recommendations on therapy, unlike how the JNC did, but again, like a good diagram to just like look over and make sure you understand like the general gist of how to treat hypertension in outpatient. Okay, next is your hyperlipidemia. And so you starting from the left, you kind of see like general cutoffs of like what's good, bad, and or good, at risk, dangerous levels of cholesterol. Sometimes these cutoffs might vary just a little bit depending on like your lab and what range they use. That's usually like a very small difference. And then in the middle, you see like the ASCVD risk calculator and how, you know, that's you can just input all your different data. And again, I think on Epic there is like a dot phrase that you can type in .ascvd, and if you like enter it in, it'll like, if you have all the information you need, it'll enter it in and it'll spit out the percentage for you, which is very helpful. And then on the right side is like a very squished diagram of like what do you do with this information, so you can blow it up in your free time and see. But just, I think in general, keep in mind that the ASCVD calculator is helpful, but also taking into account like this things like family history and like comorbidities like diabetes, which might change like how early you start someone on like medication. So going into treatment, I have on the left, just keeping in mind like this table that tells you there is a difference between like what's considered low versus moderate versus high intensity statins, and that what you prescribe might vary depending on like their ASCVD and just like other factors. And then on the right, it's just like a table of other medications that you might consider. But I think to take home from this is that statins are usually your first line, and that unless they are contraindicated. And there are newer medications now, but they're also still pretty expensive, and so they're still not very much in use yet. Okay, next is defining diabetes. So on the left is just like a fun chart that tells you how many different types of like diabetes like terms you might hear. But I think for the purposes of these slides, we'll go over just mainly type 2 diabetes. So you see in the middle, there's cutoffs for pre-diabetes and then actual diabetes. And then on the right, you'll see like, you know, your common symptoms of type 2 diabetes. And I think just keep in mind that oftentimes diabetes can be silent until it's like very uncontrolled. Like think like A1C in like the double digits. And then this I removed, but Dr. Justin Chin from last year brought up a good point that like for men specifically, if they come in for Viagra for like erectile dysfunction, like do consider diabetes, because that will definitely affect their function. Okay, in terms of treating diabetes, so if you can see, I like the very top first line, even before metformin, like say someone's in the pre-diabetes range, you always want to start with like, you know, lifestyle modifications, your diet, your exercise. I think it's like very hard in a way to really like be able to discuss like comprehensively about like what exactly are good diet changes. So I personally like will refer folks to diabetes.org because I think they explain like carbs and things like that better than I can in like a 15-minute visit. But do that first, and then in terms of medications, yeah, next would be like metformin for now, still first line. And then I know there's like, you know, you in med school you learn about all these other different things, but now like you can kind of simplify it to like either SGLT2 or GLP-1, one or the other, sometimes depending on comorbidities and insurance, unfortunately, and then go from there. And then on the right side, it's just like a table that is like a guide for like brand names, because we also don't really learn that in med school, and I'm still learning that now. Well, this slide is like a little busy. It's about insulin, what to do with insulin. I think insulin is in some ways is still like hard because when you think about, if you're starting someone new on insulin, it's like I think there's different ways to think about it. There's like you can do like weight-based calculations, and which I don't do obviously because I'm unable to tell you how to do that. And I feel like this maybe like not the best way to say it, but I honestly just do it based on vibes and very conservatively. So like you want to be conservative because you don't want to drop someone's glucose like too low. That's usually like worse than like keeping them high for just like another day. But then also like in terms of titration, you can look at this table like in terms of I think that table on the bottom is like very helpful. And then there's also the thought of like, say you started someone on insulin in the hospital, and then there's like you can do 50% of what they used the day before. If you started them on sliding scale, you make that nightly, and then 50% goes into meals. But anyways, it's like a little complicated, but you should take the time to like go through. I think that QR code is like really helpful reference on like breaking down like how to start insulin and how to titrate. And then also I'm sure like the internal medicine people also might go over it too. Okay, and then lastly for diabetic healthcare maintenance, I think this slide is just to remind you that remember that diabetes like affects like basically almost every system in your body once you have it. And so you have to keep in mind like all these different things like your foot checks for neuropathy, your eyes for like the eye exam that you have to get every year, and also like your vaccines because they are now immunocompromised because they have diabetes. So that's it. I think I'm gonna pass it off to Leena now.
Yes. Okay. Yeah, and then just to add on a little bit, so for weight-based insulin calculating, I put this in the chat and we'll continue to add commentary in the chat if folks are paying attention to that, although there's a lot of content already, so you might not, which is fine. Usually you choose the range of like 0.1 to 0.4 units per kilograms per day, and the choice is basically like how high risk you think the patient is for hypoglycemia. So if it's an older patient who's pretty frail, who's at risk of falling, then maybe you choose the 0.1 range, and then you split that usually evenly between mealtime and basal. But yes, on the inpatient side, that is something we do a lot as well. Okay, so common complaints in the outpatient setting. So I am not going to go through every single possible complaint you could ever see in the office, but I will try to pick like 3 high yield things that common complaints that you'll hear from patients, maybe as like the visit reason on your schedule, and then like what should you be thinking about before you even walk into the room. And then fair warning, you may have already noticed, but I talk at 2 times speed, which I assume is the rate at which a lot of us are used to from our lectures anyway. But if anybody needs me to slow down at any point or has a question, feel free to pop the chat. Okay, so rash. Rash is one of the things that we hear about in the office a lot. And basically, again, not going to talk about every single possible item on the differential diagnosis when you hear about a rash from a patient, but essentially the questions that it usually comes down to in the primary care office is A, am I prescribing topical steroids or topical antifungals? And then B, do I need additional testing? Sometimes you do know the diagnosis just from looking at the rash and hearing the story. But remember that additional testing is always an option. It doesn't have to be, but you can always get like KOH prep, like a stain and culture, depending on if you think there's an infectious agent, or just a biopsy, which is totally something that family care doctors should be trained to do, whether that's a punch biopsy or a shape biopsy. You can always do a derm consult, of course. And you can always look at Visual DX, which is my favorite website for skin complaints, and everybody should bookmark that if you've never used it already. So quickly splitting rash into 2 categories, it's acute and chronic, right? Like these are basically the 2 big buckets that we see rashes in the primary care setting. So, and then in acute rashes, I typically mentally split into like full body rashes versus like localized rashes. So full body makes me think of like something more intrinsic, something that like someone's body is reacting reacting to, or like something the immune system is doing. So something like a viral exanthem, urticaria, which is like an allergy thing, a reaction to a drug. And then my apologies, SSTI should definitely be in the localized category. So you should mentally move that. And then, yeah, so localized makes me think more something touched that area, right? Like something made your body develop a reaction in that specific area, whether that's like bites from an animal or an arthropod, skin infection, contact dermatitis, right? A dermatitis that come from an allergy that comes from just like touching the outside of your body. Shingles is another common one that you can see in the primary care setting that you should think about in somebody like 50 plus, especially if they remark to you that they felt something in that skin area for a while before they got the rash, and then they got the rash and there's like bubbles on it. I've actually missed that diagnosis before, and then my preceptor looked at it and was like, "That's shingles," and I was like, "Oh, that makes sense." So I put it there so that you will never forget it. And then, so those are like the most common, I think, acute rashes, like red skin things that, or like, vesicles or like bumps, lumps that you'll see in the primary care setting. And then chronically, right? I'm sure most of you have seen eczema of some kind in like your primary care or like clinic preceptorships or rotations. Psoriasis is usually the other one we think of in terms of like a chronic itchy rash. And it's usually the question is like, which one is it? Is it eczema or psoriasis? Is it the one with the scale? Like the silvery scale with the plaques, or is it sort of like a more chronic, like papulosquamous appearing rash? And then is it neither of those? Is it a fungal rash? Is it tinea, right? And then pityriasis is something that I saw a lot in San Francisco, but not so much in Seattle. As a reminder, it's the one that has like the Christmas tree herald rash on like someone's back, but it can look like a fungal infection, and it's usually confused with tinea, but it's actually like an autoimmune process that we don't fully understand that self-resolves. So that's important to diagnose too. And then other things that cause like chronic, like itchy rashes, like lichen planus. This is the like purple pruritic plaques, purple polygonal pruritic plaques. And then xerosis cutis and neurodermatitis is the tricky one. And these are just fancy words for somebody is really itchy and they keep scratching. And then their scratching leads to a rash appearance, but it's not actually a primary rash process, right? Like this is something that I think tricks us a lot, is like you think that there's something going on like eczema or something else like an infection, but actually that person is just scratching. And that can still look really gnarly, even though like it's just with their own fingernails. And then finally, intertrigo or candidiasis are things that show up. It's like redness that shows up in the skin folds. And those two things can also be confusing because you can have redness of the skin folds. Like we classically think of the pannus, right? So that area under the belly. But you can have that redness and it's not infected, it's just inflamed. So infected would be the candidiasis, and then intertrigo is the name for just the inflammation. And that's important to know because do you give like an antifungal or not, right? Or do you just need to make sure they get like zinc powder and it's not like moist and gross and they're kind of like I think of it as like an adult diaper rash because that's really what it is. And obviously you're like, why are you just talking about these rashes? Of course, I'm going to show you pictures. So here's, I want everyone to take 5 seconds before I, hit my animation of thinking about sort of like which of the big diagnoses that I just talked about, this one probably is. So this one's the history is the key, right? So let's say this is like a child, right? This kid had fever, cough, and runny nose, shows up in your clinic. Like this rash appeared like 3 days after these symptoms. What are you thinking? 5, 4, 3, 2, 1. Okay, so this is, it's okay. If you just said like viral exanthem in your head, because that's what I had listed, that's totally fine. This is roseola, right? So like a classic sort of like, this kid has a prodrome, like they have like 6 symptoms first, and then they have like a viral rash that's like their body responding to the virus that you don't need to treat the rash itself, but you should make sure that you understand like what the virus is. Isn't measles. Unfortunately, that is something that you will probably need to learn how to diagnose in your career. So that is something important to figure out. You need to isolate this. I don't know about different residency programs. We get it through UW, and so I'm sure the major academic centers have visual DX access. And then I feel like community programs must also, because it's so essential, but I don't know off the top of my head. But good question. It should be if it's not. Okay, this is another rash, full body. I'm just gonna say it doesn't really matter what this person's age is. Let's just say that it's super, super itchy. This is what the rash looks like all over their body. I'm gonna give you guys another 5 seconds to think about this. Okay, so this is urticaria, right? So this is the classic sort of, I don't know if you can tell, but there's like these like, but almost this like kind of like bubbly outline to the rash. That's how I think of urticaria. And if you really wanted to test it out, you could find a patch of like clear skin and sort of like poke it with your finger. And then you could see it like rise up in a welt, which is sort of the way that you would determine whether it's urticaria or not. And I am sorry, I just realized my video wasn't on this whole time. So hi everyone. Okay. All right. Okay. So this is kind of this is just me. So I was like talking as if all of those things in my differential were really easy to distinguish, but they're actually not. So these are like 4 different rashes, like of different etiologies, and you will see that they look pretty similar. And if instead of being like mean and making you guess what each one is, I'm gonna tell you like one of them is like tinea, like is fungus, right? One of them is an eczema, one of them is a psoriasis, and one of them is an allergic reaction. So in your head, I'll give you like 5 seconds to see if you are able to match which one is which. And it's really hard. Like it's really, really hard. So this is tinea. You can, it actually, this is like obviously all the example pictures of tinea online are like, this is clearly tinea, right? And so I was hoping to find one that's a little bit more easy to confuse, but you can kind of see this like ring-like outline to it, right? And you can convince yourself there's like central clearing. So that's tinea. This is discoid eczema. So obviously, like a reminder that like we call a lot of different things eczema. It basically is differentiated by the pathology once you look at the skin biopsy. You can see these are like disc shapes. This one over here is a contact dermatitis, and this one I put a clue in, which is this like linear shape. And this is specifically contact dermatitis from poison oak. No, I think poison ivy. And so like that contact is very clear. This is like the, the leaf or the branch or whatever, right? And then this last one is inverse psoriasis. So you can see again, all of these look very similar. And so some ways to distinguish would be like the history, right? Sort of like the contact dermatitis would be probably the easiest one because this person would be like, oh, I went hiking. This showed up like 3 days later, right? And then discoid eczema and inverse psoriasis would both be like pretty chronic conditions. Although when they are initially flaring up, it might be really hard for you to tell, which one is which. And for my purposes, actually, as a primary care doctor, it doesn't really matter which one is which, because what I'm going to do is I'm going to give this person steroids and it's going to get better. And if it doesn't get better, then I'm going to send them to derm or I'm going to biopsy it. And then tinea, again, this appearance is like pretty classic. But if for some reason you confused it, this is a situation where I could see someone prescribing a steroid, it gets worse, right? Because a steroid is going to worsen an infection. And then they're like, oh, and then this is not uncommon. Then you go, oh crap. And then you give them the antifungal. So that also happens. So that's rash. And then this one is, I'm not going to pause on this one, but you guys should all know it, right? I feel like medical schools at the very least train you well on like inpatient medicine, although sometimes you don't get as much outpatient medicine. And so this is cellulitis. Like you should just know this is cellulitis. This needs antibiotics, right? Okay. And then this is just a really quick reference for you. Always kind of like pick your favorite steroid in each class, like this, so that you don't have to look it up every time, which is what I was doing for the first 2 years of residency, right? So like, for your like low potency, it's hydrocortisone. For your like mid potency, it's like triamcinolone. High potency, like clobetasol. Like that's it. All right. So just that's basically what I have memorized. And then if I like need more detail, I go and like look in a reference. So feel free to steal this from the slides. Okay. The next complaint I was going to talk about was abdominal pain, and that is like basically this slide, right? So abdominal pain essentially can also be like diagnosed as like acute or chronic. Acute you talk about a lot in the inpatient side too, and like ED rotations, right? You're thinking like appendicitis, you're thinking rupture, you're thinking like diverticulitis, whatever. So I'm not going to spend too much time on it because in the primary care setting, you're usually seeing more chronic stuff or more indolent stuff that doesn't make someone go, oh God, I need to go to the ER, right? So most commonly, actually, I think we probably see more like left upper quadrant, like epigastric chronic pain. And that, right, tells you it's in the stomach. And so usually you're looking at like GERD. If there's acid symptom, that's really specific. Someone telling you, oh, I feel a sour taste in my mouth. I feel acid coming up, or it's like after a meal. Dyspepsia, like gastritis, ulcers, H. pylori, cancer, of course, being a critical one. And then like chronic pancreatitis is the other organ that we think about in that setting. Right upper quadrant pain, we also spend a lot of time on medical school, but just remember you can get like biliary colic, right? That is something that can present chronically as well in the primary care setting. In your lower quadrants, outside of the acute ones, you are thinking sort of more like colitis stuff, right? Like IBD, celiac also can present as like chronic lower quadrant pain from just like the malabsorption and then the subsequent diarrhea, and then like lactose intolerance, similar story. And then finally, in the primary care setting, a lot of times you, unlike, well, no, that's true. It's a hospital setting too, but in the primary care setting especially, I feel like you end up with a lot of like, unsatisfactory answers. And so a lot of times you end up with like diagnoses of exclusion. So I would actually know these really well, like sort of like, what does it take for you to decide that this is the diagnosis? So like IBS, right? Irritable bowel syndrome, not to be confused with IBD, which, and then functional abdominal pain. Symptomatic constipation is actually a big one. We tend to think of it in like older folks and like younger children, like folks who maybe can't verbalize like what their discomfort is, or who maybe just like don't have as well functioning digestive systems, but that is something that can cause people significant discomfort. And then like medication side effects. Also, I had a patient who showed up in my clinic. She had CKD, and she was saying, oh, I suddenly had this like onset of like, you know, bloating, and I'm feeling like really uncomfortable. And she's like 60 or 70. And so in my head, I was like, oh my God, do you have stomach cancer? And then I like noticed in her notes that her kidney doctor had started her on a GLP-1. So like, don't forget that like that is something, you know, iatrogenic is always something that should be on your differential too. And then again, just sort of like, so that was sort of by location, right? And then now flipping it over to like sort of by chronicity and associated symptoms. So again, like if somebody's coming in saying I have pain and it's like with diarrhea, you're thinking like celiac, IBD, chronic parasitic infections, right? You can always send a stool sample and see what comes back. You can always trial lactose elimination and other elimination diets, like for IBS, for example. And then like if literally all of your testing is negative, then you're like, okay, this is probably just IBS or functional diarrhea or constipation. So that's where you have to go to your like loperamide, fiber, etc. And then dyspepsia, again, so this is like bloating and pain in sort of more the epigastric region without acid symptoms, right? So if there's acid symptoms, it's just GERD. And if there aren't any red flags, then you can test for H. pylori. I say this because a lot of my patients who are immigrants have H. pylori. It's like a high pretest probability. And this is going to be true in like communities with like low socioeconomic status as well. You can always try an empiric PPI to see if that improves the symptoms also after you get the H. pylori test, which will be, falsely negative if you have been on a PPI. And then remembering, of course, your red flags are basically anything that increases your risk of cancer, right? So evidence of a GI bleed, weight loss, and then anyone who's older, actually, anyone with a smoking history. So that at that point you would be considering, obviously if they're like having a frank GI bleed, you're sending them to ER, but like otherwise you might be considering an urgent GI referral because they probably need an EGD or a, depending on where the problem is, or a scope. Okay. And then the last one of my symptoms, I'm sorry, I think this section got a little long, but basically I wanted to talk about cough because you're going to hear about this one a lot too. So we have chronic and subacute cough, right? An acute cough, everyone knows how to treat that. Everyone's like, okay, this is a URI or it's an asthma exacerbation or a COPD exacerbation or whatever, or it's pneumonia, right? Like you guys know that stuff. Chronic cough and subacute coughs are really annoying because the patient is going to, most of the time it's like nothing. And you're going to tell the patient, sorry, like, you know, I know this really sucks. Take some hot showers, steam it up. They're going to come back to you in 4 weeks and be like, it's not gone. Why isn't it gone? And it's just really annoying. So seeing these over and over again and knowing your mental workup really well is helpful. So the most common causes, like by just like prevalence of subacute cough, are post-infectious and then exacerbation of one of the causes of the chronic cough. And subacute is 3 to 8 weeks. Don't forget about pertussis. Again, unfortunately, in our country, these are things that are coming back. So if you're having somebody who is like coughing and getting like post-tussive emesis, plus minus, like poor vaccination history or like has exposure to small children, consider. For actual chronic cough, asthma, right? Reflux, whether that's like gastroesophageal reflux or laryngoesophageal reflux. Remember, those are they're both reflux, but they just like end up in a different place and irritate a different place. And then like upper upper airway cough syndrome, which we used to call postnasal drip, which is still the same, which is actually, if you read the literature, we don't really know what causes it. Like we explain to people that it's because of this, dripping, increased congestion, maybe from allergies, maybe from something else, going down your throat and irritating it, but we don't actually know. And then there's a wide differential, right? Whether that's like COPD, like non-asthma type, like non-allergic bronchitis, bronchiectasis, cancer. Cancer is always on the differential. Tuberculosis is always on the differential. And an older person, somebody who has like a neurologic history, whether that's like dementia or stroke, like think about recurrent aspiration. Pulmonary edema can actually cause cough. I don't think I knew that as like a medical student, but like it actually can cause we call it a cardiac wheeze, and then it can like trigger coughing just because of like the lung irritation. And then of course, like in our clinic, we harp on like ACE inhibitors causing a chronic cough, and that can happen anytime, like whether you've been on it for like 10 years or you just started it, it can cause a chronic cough. So if you don't have any other causes, you can always take off the ACE inhibitor and see if that patient gets better, because a lot of times they will. And this is the chronic cough algorithm from Up to Date, which I actually really like. So everybody should go look at that. Okay, that was my very brief, and that was sort of like adult focused. And now I'm going to talk about kids, which I don't have kids. And so pediatrics was really hard for me starting out. And now it's not as hard, but it's still pretty chaotic. I just had a child who wouldn't stop screaming like last week in clinic. So sometimes they're screaming, you're screaming, you don't know what's going on, they don't know what's going on, parents aren't going on. Pediatrics can be hard, but I'm hoping to make it easier for you. Not with this chart, because this chart is, obviously you don't have to memorize this, but this is like, in addition to the vaccine chart, this is the other important chart that like guides everything, right? This is the updated 2025, like preventative pediatric care, sort of like by age, what you're supposed to be doing. And this should be hanging up in your office somewhere. You don't have to memorize it, but you should have it somewhere where you should always be able to look at it, or it's in your epic dot phrase, whatever. But I will say, even though you don't have to memorize this whole thing, here are the important dates you do need to know. Okay, so hearing screens, you do one at birth, and then you test your kid for hearing after at like 4 years old and beyond, unless there's a concern, right? Because at 4, because you can't really, it's really hard to test them younger than 4 years old is how I remember it. So like when they are old enough to follow directions is when we start, unless again, there's a concern. Vision testing, kind of a similar thing, 3 years old, and then like blood pressure also 3 years old, like when they're able to like cooperate, and then annually from there on, right? Again, unless there's a concern, unless you're like doing your eye like reflex and you're like, oh crap, one side is like not even compared to the other, then you're on a different pathway. The ages that are important for like developmental screening and like autism screening are 9, 18, 24, and 30 months. And these are time points that you need to know. And then lead and anemia screening, most folks are getting at 12 months. Again, these are depending on risk factors and like certain other situations, but Medicaid especially like covers like lead screening at 12 months. And that's why a lot of us end up doing it at that time. And there are obviously there's like other time points too, but I feel like these are like, having just taken the boards, these are the most high yield ones to remember from the family medicine boards. And also they're the ones that are like helpful, because if your MA brings you a patient chart and is like, hey, this patient is like 4 years old, and you don't see a hearing screen on it, like then you should be like, oh, like aren't we supposed to be testing hearing? Like what's going on with this kid? Why isn't the hearing test there, right? So like this is still something you should keep an eye on. Okay. I made this last year. I think it is still relevant, but basically like what is the general structure of a well-child check, right? So like any visit, you're pre-charting, and pre-charting, you're specifically looking at their past medical history, including their birth history, if they're like a small baby. And then like since you've last seen them, like any new ED visits, hospitalizations, specialty visits. And then your vital signs, obviously you're reviewing, again, blood pressure doesn't start until 3 years old. And then otherwise you're looking at the growth chart, which is not something you look at in adults. And then you're looking at like vision hearing screening if it's available. And then vision and hearing, truly, like at first I was like, what am I supposed to do with this? Really, if it's abnormal, you're recommending that they go to a specialist. Like it's a screen, right? It's like the first step test. And if it's abnormal, you're like, you got to go to like an ophthalmologist or like or audiology to get further assessment. Usually most clinics will have have the parents do like a pre-visit questionnaire about like any concerns they have about their child, or and also a place where they can like check, yes, my kid is rolling, yes, my kid is stacking blocks, etc. So you're reviewing that. And then you finally get into the room, you talk to people, you ask about their concerns, you update their health history just like you would in any checkup. And then there's like the things of like, are they developing well? Are they toileting, sleeping? And are they like socializing? Are they in school? Are they in daycare? And then the exam I have here, the only thing to add besides, you know, doing the red reflex or whatever, is for scoliosis screening, we're doing like ideally kind of trying to catch them like pre-pubertal, because like that's where it's important to intervene. And so around like the age, like, so I think of it as like before you're doing your like heads assessment or your shade screening is like when you're doing your scoliosis screening. And then I talked about like blood tests. The Bright Futures handouts are really, really handy because basically when I hand those out, I mean, it's not good practice. You're supposed to review everything, but who has the time, right? So then I like just hand the parents the paper, and they come in like multiple languages, including Spanish, Chinese, Vietnamese. And then I'm like, great, I have given you the information. And if I have a lot of time in the visit, I will actually review everything. Suzanna had the slides for vaccines. The other thing to note is that obviously the dosing for Tylenol and ibuprofen is weight-based. And so a nice thing to do at every well-child check is to update the prescription label for your script for them for Tylenol, ibuprofen, because a lot of parents don't realize that they're supposed to be increasing the dosage as their kid gets older and their weight increases. And so this is a good reminder, especially if you're giving the vaccines that visit, the kid's going to be uncomfortable, irritated, and they're going to want a little bit of Tylenol. You don't want the parent giving them that baby dose and being like, why isn't it working? So yeah, this is just a reminder. And then sports physicals are a special type of visit. And there's a link there to the to sort of a format that you can look at. And then basically you're looking at cardiac risk. Like essentially every sports physical is like, are there any like musculoskeletal injuries that would preclude this kid from playing? And or is this kid's heart going to stop when you exercise them? And like that is basically the goal. And then this is just a brief review of the shade screening, which I think we should all be using now rather than heads, because it's like a strengths forward screening for risk factors for teenagers. And then the last thing I will say about teenagers is know when you enter your clinic, know what the rules and like process is for a confidential visit for your teenager, and know what those rules are for your state. You know, in what situations, whether it's sexual health or mental health, and what age, like 12, 13, 14, are there things that can be kept private for a patient from their parents. And then like if you're placing an order or like trying to get a test, how do you do that so that that doesn't show up on the parent's like insurance bill? So these are all important things to keep in mind, especially if you're working with somebody who is like trusting you with confidential information. This is just this is a sample like baby exam template. And these are just some findings that I like to point out. So, because sometimes you read these templates, especially when they auto-populate in Epic, and you're like, I don't actually even really know what this means. So the template will say, for example, like no ear pits. And this is an ear pit. What is an ear pit? It's literally like a little hole looking thing in front of an ear, and it is associated with genetic disorders. A lot of these things are like, we're rolling out genetic disorders in like newborn exams, and like newborn neoplasms. And that's why we care about these things. And so it's associated with like some syndromes. And so you like would recommend like an audiology assessment because it can be associated with hearing loss if you see an ear pit. Tongue ties are something else that we know in the newborn visit. And that's just because if somebody wants to breastfeed, it can inhibit breastfeeding. It's not something that needs to be addressed unless someone wants to breastfeed, or it seems like it's causing the baby a lot of distress. And then this is an example of the hip exam. And then this is the sacral dimple. We also talk about this, and again, I'm also like, I used to be like, what is that? So obviously we're thinking about like spina bifida and all those like really rare like neurologic or abnormalities where there's an incomplete closure of the neural tube, and then like the kid's spinal cord and the rest of the contents are literally like sinking down through the tube. That's like the worst thing that could happen. And so a simple dimple, which some kids can have, is not that. We don't have to worry about that. But it's more commonly seen, and so you just have to know like what makes it benign. And those are the characteristics that make it benign. Things that are concerning are if the dimple or the hole is very deep, or if there's like hair. And that is something that you would need to image further and possibly like refer to neurosurgery depending on the results. Okay, I had a brief slide on circumcision here, but I think I am running out of time, so I'm not going to talk much about it. I personally don't have much interest in circumcision anyway, so it's not like I'm unhappy about it, but know that if this is something you're interested in doing, it is something that primary care physicians and family doctors can do, and pediatricians can do too. So it's a procedure you can learn if you're interested. And then I was going to cover sort of like common complaints from a pediatric standpoint. The stuff that I will add for abdominal pain that was like not on the adult slides was intussusception, right? And volvulus. That's something you think about in like 3-month-old and 6-year-olds, and think about like bloody stool and intermittent pain. And the reason why this might end up in the PCP office is because the kid looks so okay in between the episodes, right? Like otherwise, if they were constantly screening for 12 hours straight, that kid would be in the ED. But they can end up in your office because like in between they're like fine. But if you hear about like bloody stool that like randomly happens, then yeah, definitely be concerned about that. Be aware that DKA can actually be the first presentation of type 1 diabetes through like stomach aches. So like be watchful for especially like weight loss, and then obviously like the polydipsia, polyuria, and when in doubt, like get that dip, get that point of care blood glucose. That's something we can all do in the office. The most common thing that happens, of course, is like virogastroenteritis and or constipation. Like those are the most common things that like have stomach pain, like have kids coming in for stomach pain. So let's see. This is a quick note on dietary intolerances. I don't have time to talk about this slide, so you're gonna just have to review it. And okay, I did want to talk about growth abnormalities. So growth percentiles are something that we look at when we bring a kid into the office as a vital sign. And a weight abnormality is one that crosses 2 percentile lines, either up or down, right? And a growth, sort of like an abnormal like weight loss, or either can be like normal, depending on sort of like what the family what's happening with the family and their history. It can be a sign of like malnutrition, either from like the outside, like insufficient calories, or from the inside, like inefficient like absorption or use of energy. So these are some of the differentials that you should consider once. And then like obviously like normal or familial is more of like a diagnosis of exclusion again. Height is something else that like you might notice on the growth curve if the parents don't bring it up to you first, which also often happens. And so for this one, like basically just remember there's like constitutional and familial short stature are sort of the benign ones. The constitutional growth delay is sort of like it's just like perpetually sort of like low, 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 low. And they will just they will reach a normal adult height, but the family may have a history of like late bloomers too, of like they went to puberty and they had a growth spurt and then they became a normal height. And the familiar short statures, just everyone is short. You're also going to be short. Sometimes parents are surprised by that. Like they're like, how tall is my kid going to be? I'm like, they're probably not going to be taller than you if like all of the environmental factors are the same. And sometimes parents are really depressed by that. The thing that we need to be able to catch is like growth hormone deficiency, right? And that is like sudden slowing of linear growth. And then you're investigating sort of bone age. And then if you're really suspicious, you are like getting the growth hormone level, you're sending them to endocrinology because like growth hormone replacement can actually treat this. And then finally, in the area of like looking at like the growth curve, I think we are in an era of being really aware of like pediatric obesity. And the AAP actually has been coming out with guidelines on not just pediatric obesity, but like hyperlipidemia, like and like type 2 diabetes. And so there's a lot of like, I think, eyes on pediatric weight. But just like never forget that kids like listen to everything we say, right? Like kids like listen to everything that you say, even if it's not directly to the kid, even if it's just the room to the parent. Kids are hearing that, and like our messaging can become like internalized like fat phobia and like body dysmorphia, even if we don't intend it to be, even if it's coming from the best place of like wanting a kid to be healthy. And so that I hope is like a takeaway that you guys can have. So these are different ways that like eating disorders can manifest, anorexia being the most famous one. Avoidant restrictive food intake disorder is also one that is on the other end of the spectrum that is not directly related to like body concerns, but is like for sometimes very common, like comorbid with like autism spectrum disorder, for example, where someone has an aversion to certain textures or like types of food, not because of their body. But anorexia, the thing that is important to note too is it's no longer defined. It used to be like defined by like a BMI of less than 18.5. And now you no longer have to have a low BMI to qualify for the diagnosis. All that matters is the behaviors. And again, this is important for the kids who we are labeling as obese, and then possibly encouraging almost to like take on like these abnormal behaviors to lose weight, and then rewarding them for doing so, and when actually like they are like not meeting the energy intake they need for their body to function. And so, and from that perspective, you know, like you will find like vital sign abnormalities, like menstruation will stop. They are like at risk for low bone density. They're at risk for refeeding syndrome when they restart entering calories, all of this. And then of course, like mental health comorbidities. And so it will require like a multimodal approach to really treat this condition with possible hospitalization if things are severe enough. So yeah, again, just a personal thing as we are thinking about pediatric obesity and encouraging folks to like exercise and find joyful movement and like have like intuitive eating and like that balanced eating, at the same time recognizing that our messaging is really impactful, and the way you talk about it matters. To you, Ryan. Sorry I went over.
So I'm going to be talking about prenatal care, and I think this is one of my favorite topics to talk about because this is one of the few times where patients are coming to the clinic really excited to learn more, and they're not always super sick. And it's a time where you can actually get to know people and their goals and share that joy with them. So we're going to talk about like from start of the pregnancy all the way to delivery, and we will not be going into delivery itself. But these are some like simple tricks and kind of tips to navigate the different stages of pregnancy. So the first visit, we often give ranges for dating, and that's because people don't automatically know, like they don't wake up and they're like, oops, I'm pregnant. Like oftentimes it takes time, and that amount of time varies. Based on when people like realize like, oops, my period hasn't come, or maybe they weren't intending to get pregnant, and so on. So um, for the first visit, we're often confirming that there is a pregnancy there. We usually try transabdominal ultrasound first. And if we're not able to visualize the pregnancy, then we switch to a transvaginal approach. For the transabdominal, we ask that patients have their bladder full, and that helps bring the uterus into view. And if we're not able to see it, then we switch to the transvaginal approach, and we ask that the patient go to the restroom so that the bladder is empty, and that makes the exam easier to maneuver. In terms of dating, we do a couple measurements of the pregnancy. As you can see on the slide, there is like a little flower sign and then dotted line measuring the length of the pregnancy. And that length kind of tells us like, oh, the pregnancy is maybe 8 weeks old. We compare that to the last menstrual period date, and depending on the level of variance, we either say, yep, let's go with the last day of your last period, the day of your last period, or if it's really different, then we say, actually, we think that the ultrasound is more accurate. Let's go with the date based on our exam. Once we've decided, yes, there's a pregnancy, then we should always be counseling, like, is this what you want, right? Some people, they really desperately want to have a pregnancy. Others, it was unintended, or it could be an even worse situation where, for example, like sexual assault or human trafficking or coercion. And so we, as healthcare providers who are providing prenatal care, we have to make sure that we are advocating best for the patient first. Beyond that, there are a bunch of other things that we talk about, and it's actually quite comprehensive. The first visit often runs over time, in my experience, because we're asking about their social history, OB history, and talking about all these different labs. I think I will just emphasize a special situation, at least for the clinic that Leena and I have done training in. We see a high proportion of patients from East and Southeast Asia, and depending on where your patients come from geographically, there may be a higher degree of prevalence in terms of alpha, so like alpha thal or beta thal. And so we will often add on hemoglobin electrophoresis as well as alpha globin gene analysis in that first panel of labs. So moving forward for all the other visits, regardless of what part of pregnancy, we always ask these 4 questions. Is there any bleeding? Have you had a big gush of fluid? Any contractions? And has fetal movement, and that starts around 16, 20 weeks or so, and it should continue regularly all the way until delivery. Let's move on. So for the first trimester, that's 0 weeks to 14 weeks. Usually we have appointments every 4 weeks during this time. And a couple kind of key points to clue patients into: miscarriage is really common, 10 to 20% of pregnancies. And we always start with, this is not your fault, because most of the time patients will assume that it was because of something that they did. And frankly, we just don't know why some pregnancies end up in miscarriage. Another thing is treating nausea. And so oftentimes like patients will try their own thing, whether it be like ginger, ginseng, or like other anti-nausea medicines they have around. The evidence shows that vitamin B6 is actually what's most effective for pregnancy. And then you can add on some other adjuncts as well. And then another key thing that patients often ask about is genetic testing. We're moving more and more towards cell-free fetal DNA for most patients, and that's at 9 weeks of gestation or above. And then we're also doing an early anatomy scan at 12 weeks, as well as checking fetal heart tones around 12 weeks. So that's just using a Doppler in the clinic on the belly or near the pubic bone, I guess, at this stage, and just listening to the heart tones. Second trimester, that's 14 to 28 weeks. This is actually like the golden trimester for most patients, where they have way less symptoms and their pregnancy isn't so big that it's uncomfortable to move around. And so oftentimes this is a time where patients are like, oh my gosh, yeah, pregnancy is great. I love it. We continue with Q4 week appointments. The big markers here are we do an anatomy ultrasound at 20 weeks, and that's to look at all the different parts of the pregnancy to make sure that there are no fetal anomalies. Between 24 and 28 weeks, we do our glucose tolerance test, and that's to check for gestational diabetes. And then at 28 weeks, we do the last blood draw, theoretically, for anemia screening, as well as giving a Tdap shot. And that is for pertussis, so that baby gets immunity before they're born. Third trimester is 28 weeks onward. And as we get closer and closer to term, we increase the frequency of appointments as things are rapidly changing. So 28 weeks at 36, we say 2 weeks appointments. And at 36 weeks onwards, we see people every week. At 36 weeks to 38, we get a GBS swab. That's for group B strep, and that determines whether we want to give antibiotics at least 4 hours prior to delivery. And then we spend a lot of time talking about what is labor, what do contractions feel like, and when to go to triage. But yeah, I think that's it, and I'll just pass it back to Leena then.
Hi, me again. In case you didn't get enough of me talking, here we go. So we've talked about how to have children. Now we're going to talk about how not to have children. So birth control. Basically, whenever a like patient with female anatomy comes in to talk to me about birth control, I show them like some version of this chart, right? So going from like condoms to like the withdrawal pullout method or fertility based awareness to like IUD. There's like a range of options, more and more now, and all like increasing in effectiveness in that order. But also again, like the method that works the best is the method that the patient will use. So I always talk to patients about sort of like what their preferences are. Just a reminder that you essentially have like 2 types of hormonal birth control, right? So like the 3 big kinds of birth control are like non-hormonal, hormonal like estrogen based with progestin, and then like hormonal only progestin, right? So like non-hormonal would be the copper IUD, which like acts only by like just having creating sort of this like toxic inflamed environment that is like hostile to sperm. And then you have like all the progestin IUDs, and Nexplanon and the Depo shot, and those are all progestin only, which is safe for people for whom like estrogen is contraindicated due to history of migraine, cigarette smoking, clotting or stroke or clots. And then the estrogen-based methods, which are the pills, the patch, the ring, and then sort of the other like non-hormonal based methods include like physical barriers, like the diaphragm, the condoms, and then spermicide, which I feel like I've not prescribed for someone yet. No one has asked me for that, but it is available. And this is just a quick comparison chart of sort of all the hormonal methods, in addition to the barrier methods at the bottom, and basically describing like the method of action, and different sort of like side effects to know about. The biggest ones for the progestin-only methods, of course, is that the bleeding tends to be more irregular and hard to predict. But for the hormonal IUDs, almost certainly the bleeding will be less, versus for the copper IUD non-hormonal, which is a lot of times what patients are hoping for. The bleeding and pain and cramping with each like withdrawal bleed period will unfortunately be greater. And then every time you're prescribing, if you're prescribing the birth control, that presumably means they haven't been on birth control. So make sure you get a urine pregnancy test, because if you are using an emergency contraception method and birth control combo, for example, with the copper IUD, you at least want to know about it. And if they are pregnant and you are not prescribing a method like that, you also want to know about it. And then for all like non-IUD methods, make sure that you counsel on a backup method for the first 7 days. Like for example, if you're prescribing Nexplanon. And this is a comparison of all the IUDs that are currently on the market. So ranging in terms of like how good they are for like 12 years for the Paragard to 3 years for the Skyla. And then actually, in addition to the copper IUD, aka the Paragard, Liletta and Mirena, which are hormone IUDs, are also now effective as emergency contraception, which is great. Just gives patients more options. They're not stuck with the copper IUD if they need emergency contraception in that visit. And this is another note about emergency contraception. Which is basically, this is not up to date because we have the other 2 IUDs as well. And then there's like the 2 types of pills. UPA, aka Ella, is good for up to 5 days. And then progestin EC, aka a Plan B, is good for up to 3 days. The thing to note is, unfortunately, I think the 2 pills were not tested on populations with like higher BMIs. And so they like note that like because of sort of the distribution of the drug, they can't guarantee that it'll be as effective. That's my understanding. And I don't know if someone is conducting trials to correct that historical malignment, but that's just the data that we have. And then, of course, a short note, vasectomy is a procedure that family medicine docs can learn to do in the office if you're interested. We don't do bilateral tubal ligations or hysterectomies, but always remember that for your patient who, if they're just done having children, like they know they won't want more, like always something to offer them and offer to them and discuss with them. Cool. Kind of continuing along this like gynecological train, we are going on to sexually transmitted infections. So this is the sort of clinical scenario I came up with, which is just like a patient, like young, healthy, walks into the room and is like, hey, they're sexually active, they tell you, and they just want to get tested for everything. Like that's why they're here. It's like, what is everything? Right? Like I feel like that's a question that you need to know the answer to. So I think gonorrhea, chlamydia is probably like most people's, like people know that one. Don't forget that you need to test all the relevant orifices, right? So this is where it's important for you to take a good sexual health history, like what kind of intercourse is that person having, like what body parts are involved. So we can test like urine, we can test the pharynx, we can test like the rectum, and if possible in your clinic, like always offer someone the option to self-swab, especially for like the rectal vaginal swabs if relevant, because that's always a better trauma-informed approach if somebody prefers that. And then obviously HIV, which Ryan will also talk about HIV a little bit more later. Syphilis is something we can also offer. And then like hepatitis C, some people will also include in sort of that like PAN, like sexually transmitted infection testing panel. And there's some small notes here to like help counsel patients about like, well, depending on how recently you had, for example, like unprotected sexual activity, like you may need to come back in like a few more weeks for us to retest this, because like if you contracted something during like your intercourse 2 days ago, we're not going to see that. So that's always something important to keep in mind. And then other things to consider would be if somebody has a vagina, like a vaginitis swab, trichomonas, yeast, and BV will show up on that and are treatable. Of course, there's like some bodies that say there's like no point in testing if somebody is asymptomatic, but I think like, you know, if somebody has trick and they could be passing it to a partner, it's always good to know. Genital herpes is something you can also offer. Hepatitis B is like less commonly transmitted sexually than hepatitis C, but still something that can be offered. And then HPV screening, obviously like follow the ASCCP timelines if they have a cervix. There are some clinics that do have the setup to do sort of like a rectal exam in cytology for rectal intercourse if somebody is participating in that, but I think that's very rare. It's like more specialty like MSM type like clinics. So and at least our clinic doesn't have that, but consider it. And then don't forget that somebody can get Gardasil, right? Even up to, I think insurance is still covering it up to age like 40 or so. Most insurances are. And so if like somebody like missed the window is like in our generation of like too old to have gotten it when they were in school or whatever, like make sure that they get their 3 doses. And then post-exposure prophylaxis, PEP, I think, Ryan, you might be talking about? I can't remember. Yes, yeah, you're talking about PEP. So I'll talk about DoxyPEP, which is, in addition to PEP for HIV, we also have DoxyPEP, which is for syphilis and chlamydia. And that is, there's a CDC guideline out for now. It's 200 milligrams within 24 hours and no later than 72 hours. It is unfortunately less effective for gonorrhea. So it's really meant more for syphilis and chlamydia. And then technically, and I've prescribed actually this battery in the setting of somebody who was sexually assaulted and sort of like needed, you know, everything. So you can also give like oral metronidazole to treat preemptively for like BV or trick in that setting. And then don't forget to again, like do sort of like repeat testing later in case things didn't show up in your first round of testing. This is just my quick, you know, my favorite topic, which is sort of like differential based on different symptoms. We don't have to talk about this right now, but if it's helpful for you, you're welcome to come back and review the slides. I also do talk a little bit about genital lesions here. So again, like some skin pictures. Here's like vesicular painful ulcer that is symptomatic of herpes. And then here is like a painless ulcer that I think is primary syphilis. Yeah. And then this is sort of like the CDC treatment guidelines, which I think were briefly taken down by our administration and are like back up, but they're summarized here for you in case these are helpful. And then just remember that if you test positive for one STI, make sure to test everything else because they tend to run together. And then, you know, it's know like which of these are supposed to be reported to the Department of Public Health and who does that at your clinic. Most of the times for us, it's our lab tech, sometimes it's the nurses, but sometimes it might be you. So just be aware of that. And then to note that like trick BV and HPV are actually considered like sexually transmitted infections between like women who have sex with women. And so that is something that you should be aware of too. Okay, back to Ryan.
Yeah, actually, we can take a quick 2-minute intermission break right now, and then we'll come back in a couple of minutes. Thanks.
Oops, sorry, I was muted. All right, so I know Leena just talked about how to prevent pregnancy. We're going to talk about abortion care. So what happens when people are pregnant and they don't want to be pregnant anymore. There are really 2 main ways. One is medication abortion and the other is surgical abortion. So we'll start with medications. Naturally, given that based on the size of the pregnancy, medication abortion can only be done up to 10 to 11 weeks of pregnancy. And the structure of it really kind of depends on the agency that you're going through, whether it be Planned Parenthood or a less well-known abortion service. But most places start with, on day 1, you give a dose of mifepristone, which is 200 milligrams. And then from day 2 to 3, we are giving buccal misoprostol, which is a medicine that we often use in labor. And in conjunction with these, the misoprostol can often cause a lot of side effects. So we recommend that people take pain medicine, so like ibuprofen, and nausea meds such as ondansetron. And if patients are already beyond 9 weeks of gestation, we often recommend that they take an additional 4 tablets of the buccal misoprostol 4 hours after the initial dose. And generally, with this regimen, most people will pass the pregnancy within 24 hours vaginally. That'll include cramping and bleeding for up to 8 weeks afterwards. And on day 14, we always recommend an ultrasound to confirm that the pregnancy has passed already. And by passed, I mean is no longer in the uterus. For surgical abortions, this is it varies how we do it based on gestation as well. So 12 to 14 weeks usually is the cutoff for a in-clinic same day sort of aspiration. And anything beyond that requires a D&E, which you need to either have special training for or go to OBGYN and family planning. The premedication for this varies a little bit differently since we will be using instruments inside of the uterus. So we usually give people doxycycline 200 milligrams as prophylaxis, as well as ibuprofen, misoprostol, ondansetron, and diazepam. And I want to mention the misoprostol here is actually kind of a dual mechanism here. Not only does it help with the pregnancy passing, but also in terms of like using instrumentation through the cervix, it allows the cervix to be softened. And how does this look like from the patient's perspective? So they arrive, they get an ultrasound done to confirm that there's a pregnancy and also the gestational age of the pregnancy. Then we do a bimanual exam to assess what orientation the uterus is kind of facing to inform how we will be positioning our instruments. We then do a cervical block, and style varies dramatically here. Some people do like 2.5 cc's of lidocaine, kind of at 12, 3, 6, and 9. Some people do 12, 4, and 8. So just try out different methods and see what works best for you and your patients. Then we do dilation, and that's like serial dilations mechanically. And then from there, we either do an MVA or an EVA, so mechanical vacuum aspiration or electrical. Um, so this is kind of like a picture of all the tools that we use. So on the far left side, that is kind of the long syringe needle that we use. Usually we actually have a needle extender, and that's for the cervical block. Just right of that is the MVA, so the instrument that actually provides suction to remove the pregnancy. And then so right of that is the curette that we attach to the MVA. And then the other instruments on the right you probably are familiar with, so tenaculum, ring forceps, and the speculum. And then on the bottom, those are the dilators. So effectively, we usually start with the sizing is pretty arbitrary, but conveniently, the number on the dilator kind of correlates to the week of pregnancy that you may need for the curette to um, be able to fit the products of conception, if that makes sense. Because as time goes on, the products are larger, right? So we start with 4 to go through the cervix, and then we switch to 5, 6, 7, 8, and then to whatever week of pregnancy that the patient is at. That is a brief overview. People do full certificate programs, or they do an area of concentration, or even do fellowship to do abortion training. So there's much, much more to that, but we'll move on to HIV care. So number one for primary care, it's like, okay, who even needs to be screened for HIV? And effectively, there are kind of two main groups. So one is pregnant people, and this is repeated at every single pregnancy. And then just given the risk, the high morbidity and mortality for the pregnancy, but then also given that to get pregnant, you need to have sexual intercourse. It's just a higher risk population. And then anybody who's 15 to 65 years old at least one time in their lifetime. So we'll talk a little bit about two different ways to approach this. One is prevention and the other is treatment. So PrEP or pre-exposure prophylaxis is the first of the two that we'll talk about. And basically, like, so beyond like who should get tested, the other question is, oh, who should get PrEP? And effectively, any patient who comes into the clinic and they're like, I want to have PrEP, um, generally I would adopt a no questions asked, like, sure, you can have PrEP if you want it, because most people who are worried that they're going to contract HIV end up being high risk. I've had like one situation where somebody was like 60 years old, not sexually active, identifies as heterosexual, and had not been sexually active for years, was asking for PrEP, and also had no history of IV drug use. And that was like really the only time where I was like, tell me more. But otherwise, I think generally if people are asking, you can assume that they're really, really worried about it and they may be at high risk anyways. So these are other high risk populations that you could consider talking to if they did not talk about PrEP yet. So these are partners with known HIV, people who have 2 or more partners of unknown status, inconsistent condom use, STIs in the past 6 months, or sharing injection needles or equipment. So what does PrEP look like? There are a couple different ways to do it. One is oral, so pills. And there are 2 main regimens that a lot of people are familiar with. One is Truvada, which is tried and true, and the other is Descovy, which is a little bit newer. A lot of people are familiar with it now, though. There's really one main difference here that I would highlight, and that's just talking about EGFR. So there is a lower cutoff for Descovy. What does that mean? If people have kidney impairment, we'll probably recommend Descovy over Truvada. Um, and the only caveat is that Descovy has some mild evidence for weight gain and dyslipidemia. And also, Descovy is not studied in people who are having receptive vaginal intercourse. There is a new kid on the block, though, that has been under testing for at least a few years now, and is gradually building traction. And this is cabotegravir, which is an injectable form of PrEP. And I would really recommend this for a couple different people. One is people who don't like to take oral meds. Another is people who have a difficult time with adherence. And basically, how this works is you give 1 dose on the first month, you give a second dose the next month, and then after those first 2 doses, you do it every other month. So if you look at this table in the first, or I guess the second column with the colors. So injectable, it starts January and then February, and then you skip months. So it goes April and then June from there. There is an alternative protocol that you could use, which includes an oral lead-in. And this is for patients where you are worried, like, oh, they have like a high sensitivity to medications. It may not be the best idea to inject them with a month worth of meds right off the bat. So you can give them an oral formulation for 28 days, and then the next month have them come back in and be like, hey, how did that go? Did you have horrible side effects? If not, then you can proceed with the injectable regimen, which is the same as the one above, just move down 1 month. So let's say now you're encountering a patient who has contracted HIV. There are so many different things that we could talk about, but I will just start with the basics that some people may not have heard of. So one is characterizing the HIV. So much of the medications that were developed were because of resistances. So how do we characterize resistance? One is if there is active virus there, you can test the virus itself. And so by that is called the GeneAssure Prime. And by looking at the virus itself, it's like, aha, okay, we can see the genetic mutations here, 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 here. And you can punch it into a calculator and then it'll tell you like, oh, okay, protease inhibitors, not a good idea for this patient, or NNRTIs, not a good choice, or what have you. To look at the virus, there has to be a viral load, right? And so for a patient who has been on a regimen for a long, 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 long time, and they're like, oh gosh, like I don't really like the meds that I'm on, but their viral load is undetectable, you you won't be able to do the GeneAssure Prime, right? They're already suppressed, and so the alternative is the GeneAssure Archive, and this is looking at the patient's DNA, since this is antiretroviral, retrovirus. So HIV, as we think about like the pathophysiology of it, incorporates itself into the DNA, and so you're testing the original HIV that was embedded, and it gives you a sense of what the mutations have been, but not since after treatment in that specific patient, if that makes sense. So it's like a okay way to check for resistances, but not super, super accurate. Um, and then effectively, if a patient does not have a very complicated history, most of the time people are on Biktarvy these days, which is an NRTI, two NRTIs with an integrase inhibitor. And then the last concept I want to impart with y'all is the goal is viral load is undetectable. And from there is born this slogan, U equals U. And you can just share this with patients and drill it into their heads of U, the first U being undetectable equals untransmittable. And so for so many patients, they have this internalized stigma of like, oh my gosh, like I could hurt somebody, they could die from this, like I shouldn't be able to express myself or engage in sexual activity with others. And no, you can empower people like, hey, actually, you've been really good on your meds. Undetectable equals untransmittable. And so as the doctor in the relationship, you can say, like, it is safe for you to explore and meet other people and have sex, and you shouldn't bog yourself down with that. So we will move on to geriatrics. So I'll pass it to Suzanna.
Here we go, geriatrics. And I'm also going to be borrowing some slides from Ryan since he they presented on it last year. So the first slide is on the Medicare annual wellness. And usually there's like a template for this in Epic and your other EMR systems. Typically, I think your MAs or your nurses will like start it, and when they're rooming the patient, they'll like add in all this information. And I wanted to highlight that. So you obviously start this when someone is eligible for Medicare and they're over 65. There's like a welcome to this, and then you just do this once a year. It's like, and they have to do it for, I think, like insurance purposes to like keep up their Medicare. But then specific parts of this visit, which is not present in like your other adult annual visits, is you have questions that go over like function, so like your ADLs and your IADLs, which I have kind of listed on the right side there. You go over like urinary incontinence, fall risk, vision, hearing. You might do like a more in-depth like social determinants of health screening. You might do like a mini cog assessment, which you see that little clock on the bottom is like part of that assessment. And then you go over advanced directives, which is very important and something that, you usually might not have time to go over in other visits. So this is like a good time to just like look over to see if the patient already has something on file, and if they don't, try to like start that conversation today. Okay. A quick slide on dementia. So on the right side, I just wanted to highlight like what is considered normal aging, what is then like maybe a mild cognitive impairment, and then what you can start considering as like dementia. And I think to kind of summarize, like if you start noticing decline in cognitive domain that's like affecting the functioning of that patient, then like you're heading into like dementia territory. And then on the left side, it's just like your 6 different cognitive domains, and the bottom part is like an example of what that looks like, how you can test it. And then one of my faculty members who's geriatric trained, she always likes to emphasize that you know, when you're assessing for like dementia and also like delirium, it's not just like saying like, is your patient oriented ×3, but also like, how is their attention? Like, can they spell world backwards, or can they like count backwards from like 10? Next is polypharmacy, which is, you know, a very big issue. Like, you're gonna see patients with like 15, 20 plus medications, but if they have any more than 5, that's already considered polypharmacy. 15% of older adults do report adverse drug events in the first 6 months, and 25% of these patients are hospitalized for med-related problems within 5 years. How do you know if someone has polypharmacy? And you can start by checking the Bears criteria for any meds that might be inappropriate and or have like drug-to-drug interactions. And then how do you fix this? Like, it's definitely hard, especially if someone has like a 20 item list for their meds, but these two websites that Ryan had listed last year, I think, are very helpful to learn how to de-prescribe some of these medications that are like not as essential. Hearing loss. Oh gosh. Okay, I didn't realize that when I advanced the slides, the picture of the of the hearing aids will be there, but basically if you can kind of look around them, common concerns that like patients might bring up, like they might start saying like, oh, I hear just fine, but like not, I can't really hear my grandchildren, or it's too noisy when I'm eating in a restaurant these days, etc. And you want to keep in mind that for like, as part of normal aging, sounds that patients might start to lose first are your high-pitched sounds, soft voices, and also just like speech, especially in like a loud environment like a restaurant. And I think what's helpful, like before you talk about hearing aids, what's helpful for helping those patients hear better is not necessarily like increasing the volume at which you're speaking, but it might be more helpful to actually speak slowly, to, you know, temporarily like pull your mask down so that they can read lips, because a lot of people start relying on that when their hearing starts to go. And then also speaking directly into their ear, like right next to their ear. And then this picture in the front and the slide on the right kind of just details like all the different types of hearing aids that are available on the market. And, you know, it's very important to make sure if a patient is admitted that they have their hearing aid with them, because that will, if they don't, that'll also like lead to like delirium, increase the risk of delirium and things like that. Okay, so driving safety. Yeah, I think something to just keep in mind that while this is a concern, but most older drivers are safer with less risky behaviors than our younger adults. And so you want to try to make this very objective when you're assessing for this, because a lot of people will feel like, you know, you're taking away their sense of like freedom if you do have to take away their license. So you want to go over like parts of the exam, like general, like just how they feel about driving, like, you know, can they still drive at night and things like that. You want to go over their vision, cognitive, motor, sensory, range of motion, like are they able to turn their neck and check their blind spots and things like that. In theory, there is something called a driving rehab specialist, which I don't really know about, you know, in my area, but also Medicare rarely accepts this, so you can't really get it paid for. And then lastly, you know, as their physician, we do have an ethical obligation to like report when we think someone's not safe for driving anymore, but it's not required in many states. Really only in those that are listed there, and then only in Washington, D.C. do they require a retest at 75. For difficult conversations and advanced care planning, sorry. So again, there's that picture in the middle, so you can like drag it to the side when you do look at your slides. But the spikes, the spikes acronym is what I'm most familiar with my like medical school education, so that's why I have this here. You can Google it and, see what each stands for. But in general, you're trying to like, pick a quiet, private setting. You want to see like how much the patient and or family knows. You want to ask permission, like, oh, okay, can I share this like with you? How do you like information shared? And then, you give the information, address the patient's like emotions or reactions, and then you like strategize, you plan like, next steps. But a separate guide that Ryan had listed last year was the Ariadne Labs Serious Illness Conversation Guide, which I did take out that slide from this year, but that one has like a more helpful like infographic, so you can also try looking that one up. And then just a quick slide on like what palliative care is, which I'm sure Ryan can talk more about if you would like to know. But palliative care, I think like gets confusing because he will talk about palliative care versus like hospice. But I think, from my understanding, hospice is like under the umbrella of palliative care, and they share a lot of things in common. But palliative care, you can start that like whenever, at any point in a disease. It's for like these more serious illnesses, and you can have these services at the same time as curative treatment. Whereas for hospice, it's like paid for differently, and because of that, there's like different rules. So like a patient cannot be on any curative treatment anymore, and also technically like their prognosis has to be like 6 months or less. Like sometimes we can be wrong. Like I think I had a patient who had been on hospice for like 2 years and was still actually doing pretty well. But that is not the majority of patients who go on hospice. Advanced directives, I think this terminology also can get confusing, but advanced directives can refer to like any of these documents that are listed here. So oftentimes you hear someone talk about a living will, and that what you would like if you can speak for yourself. So that includes your DNR, DNI order. It can include the pulse form. It can include organ donation and like brain donation, like for like science purposes. And you can see like on the side, I include a picture of 5 wishes, which is a document that I actually like learned about and reviewed through med school. And I think that one is a pretty like intuitive document that really walks you through like all your different options. And then there's your durable power of attorney, where you can specify who can legally speak upon your behalf if you can't do so yourself. Lastly, code status. So this is really important to know, because you have to ask this anytime you admit someone to the hospital, and also can be an ongoing conversation throughout admission. And so yeah, like what do you do if someone dies? And I think it's important to use the word like dies, because I think some people like, oh, like my heart stops, but then like they basically died, and you have to bring them back to life now. And I think that helps convey some of the gravity of the situation. And so you can be like full code, which includes CPR, intubation. And it is a good point also to remember that like in very few instances, if someone goes through CPR, like they will probably need intubation to continue going, and vice versa. I think the EMR lets you do like isolated DNR or DNI, and there are specific situations where you can do one or the other. So it's important to kind of explore that of the patient if they're interested in that. And then obviously there's your DNR, DNI. Okay, hold on. Okay, and then for deaf, which I feel like is not really talked about as much in med school education. So just on the left, you see a slide on like what is brain deaf. I had to learn this as I was preparing, because I feel like it doesn't come out as often. But brain deaf is like when you have permanent loss of your brain function. So that includes cognition, consciousness, but also things like breathing and your heart rate. And from my understanding, you do need evaluation by a doctor trained in a brain deaf evaluation. And parts of that evaluation then include, is the patient in a coma? And so you can do things like, are they responding to painful stimuli? You can check brainstem reflexes, like your corneal reflex, your gag, your cough, and then you do an apnea test where you would take someone off a ventilator and then see if they actually stop breathing for like a number of seconds. And then on the right side, there's like symptoms of active dying on the top. I kind of wrote out like the difference between, you might hear people talk about agonal breathing or like the death rattle. And I think it's just good to start kind of learning these signs, because you'll have patients who like, and or families who like ask you like, how much longer you think someone has, especially if they're on like comfort care now. And it's always very like hard to say. But I think if you notice some of these symptoms, like you can maybe try to give like a ballpark estimate for people. But of course still being like, still really don't know. And then steps to like pronouncement, the AFP has like a good like detailed article that I just referred to that's from like 1998, but I think it's still very relevant. So if it was unexpected, you want to make sure you ask the nurse for details of like, okay, like what happened, what were the vital signs, things like that. And then if it was expected and, not after a code, you kind of, if the family is in there, you want to introduce yourself and explain why you're here. You're here to pronounce them and ask if the family wants to be present for this. They can always step out. And then as part of the exam, you want to note the general appearance. You want to check their tactile, response to tactile verbal stimulation, check their pupils, and then listen to like their heart and lung sounds, check their pulses. Then you want to document, and you want to call the family if they weren't at bedside to tell them the news, and then ask if they want an autopsy, because you'll have to note that later when you're documenting, and then you'll have to fill out the death certificate afterwards. I think just some pearls of this, especially like, I think I was talking mostly about adults when I was preparing this, but definitely if you are in pediatrics and you're talking about death of a child, you want to mirror the patient's body language. You can use as few words as possible. This like helpful script from the AFP article I thought was really good. You can say something like, I'm Dr. So-and-so. I'm terribly sorry about the death of your child. I'm here to examine him or her. And then you can say something like, you can hold your child as long as you want. The nurses and I are here if you need us. And then like, that's it. Like silence is okay. Comfort them. Yeah. And then again, in general, you want to be empathetic. You want to avoid over personalizing, and like by saying things like, I know what you're going through, because you really might not a lot of times. And again, okay to be quiet, okay to have silence. When to call a coroner specifically, if a patient has been in a hospital less than 24 hours, if the death had unusual circumstances or was associated with trauma, associated with trauma regardless of cause of death. Like, for example, right now I have a patient in the ICU who is trached and pegged and probably might die, I don't know, from cardiac arrest, probably. But like their trauma, like someone like pushed them and they fell or hit their head. And so this would be reported to coroner when they eventually pass. Okay, on to Leena.
Okay, so switching topics, I'm going to be talking about addiction medicine, and acknowledgement that these slides partially come from Dr. Semi Wenzel, who cannot be with us this year, but made these slides last year. Okay. In general, when you're thinking about substance use disorders, right, you're thinking about for each different substance, what are the immediate and chronic health risks, right? Like, why am I even concerned about this substance? Why is it my business? And then secondly, you're thinking about what the withdrawal looks like, how to treat the withdrawal, and then in an overlapping sense, sort of how do you support a patient through rehabilitation? If somebody is like motivated and wants to be off of the substance to treat their use disorder, like how can we do that? And then a reminder that just because somebody is using a substance does not automatically mean that they qualify for disorder, right? And so there are like many factors in the DSM-5 that go into diagnosing someone formally with a substance use disorder, and a lot of them include behavioral things. In addition, like for example, like using the substance or seeking the substance despite like negative impacts on their life or health. A lot of our patients do fall into that category, but still important to note that not everybody automatically does. And then in addition to like noting that like the use disorder, someone's like physical tolerance of the substance, like needing more and more to like get an effect, and the like physical dependence that they have on a substance, like feeling negative withdrawal symptoms when they're off of the substance, those are all different things. And so like mentally being clear on that in your mind helps you understand sort of like what the pathophysiology is, and like what a patient might be experiencing. And again, like these conditions are the same across all substances, right? Like the qualification for the DSM-5 diagnosis, regardless if it's like opioid or alcohol or cigarettes, it's all you know, in the sort of like addiction like spectrum. This is how we would qualify somebody as having a disorder. Okay. So general principles for taking care of folks who have substance use disorders, or in general, right? If you're open to screening like everyone, which you should be, is like taking a complete substance use history. So the big focus for a patient in that moment might be one particular substance they're using, but it's important to know what else has been in their past, right? So like a way that I've heard like addiction specialists phrase this question is like, what substances are a part of your life or have been a part of your life? And I think that's like a really open-ended and like non-judgmental way of asking it, instead of just like, what are you using right now, or something like with a stronger attitude. In addition to this, like acknowledging any like history cessation attempts, right? Most of the time, somebody who has fallen into the category of qualifying for a substance use disorder has been dealing with this on their own for a long time before they even bring it up to a physician. And so most people have tried at some point, and so it's important to acknowledge that, and like, you know, the strength that that takes, in addition to knowing that, you know, you're not going to try something that they've already tried before and failed, because that would be wasting your time and their time. Obviously, a lot of like substance use disorders are coexisting with mental health conditions, right? Most folks are like self-medicating in some way. And so treating those mental health conditions is really, really important if you and the patient like want to make sure that they are safely off of the substance. When you are prescribing anything, checking the PDMP, prescription drug monitoring program, is really helpful, because then you know, and it's you know, not just about like keeping a close eye on them, it's more about like knowing everything they're taking so that you are prescribing treatment safely, and not giving them, you know, if they're like already getting opiates for someone else, you're not giving them like a shit ton of benzos that like they could take all together and like overdose on, right? Like you want to know that. And then be familiar with your urine drug screen. So like different clinics and different like testing corporations like use different urine drug screens. And then the ones that are the one that you have, the point of care, that is just like the dipstick that you get the result in clinic instantly, is going to be different from the one that you send out to your laboratory. And there might even be specific tests that you have to add on to your laboratory test. For example, for fentanyl, which is like a unique synthetic opioid that doesn't automatically show up on most traditional urine testing. So be really familiar with that, because like that is something that if you have a positive result, you are obligated to talk to your patient about, and it'll be really awkward if you don't actually know what it means, right? And again, like really important to be open-ended when that happens. Just say, hey, this showed up positive on my test. What do you think about that? And just let the patient sort of like fill in that story. And then always send out, if it's like a office urine positive, for confirmation. Always send out for confirmation, because the false positive rate of these tests in the office is actually really, really high. And in general, like most substances except for like THC and fentanyl show up about 3 days after last use. And like it's important to know a lot of these are long lasting too. So like THC can last for like a month. Fentanyl metabolist can last for 2 weeks. And this is especially important because, for example, in our breastfeeding mothers, our parents who want to chest feed, like fentanyl in our hospital, for example, like a positive fentanyl test is something that can preclude them from chest feeding. So understanding that that is not necessarily indicative of like a use that they just had like 2 days ago. And then remember always to like, although we're as doctors, we're focused on problems and solving the problems, it's important to affirm what patients are doing well and to hold firm boundaries. And it's hard to do both of those at the same time, but they are not mutually exclusive. Okay. So in general, I'm not going to go into detail about this each time, but
Alcohol, benzodiazepine, opioid withdrawal, because these are all like sedating substances, their withdrawal looks a little bit similar, and they have like a coexisting symptoms. So for example, like withdrawing from any of these substances, people are going to feel anxiety, they like irritability, insomnia is a big common symptom here. And then depending on the substance, you might have like GI symptoms that are more specific, or like muscle aches and things like that. But because of that, we have what we call sort of like adjunct medications or blue plate medications. These are medications that do not directly address the substance itself. Like they don't act on the same receptors necessarily, but they can help people like get through some of this discomfort that's associated with withdrawal. So I've just listed some of them here. For example, hydroxyzine for anxiety, gabapentin for anxiety and sleep. This one specifically is helpful for alcohol and benzo withdrawal, but you can use it in opioid too, because it works in the GABA receptors, and that's like more directly like how alcohol and benzos work. Obviously, like anti-nausea medications you guys are familiar with for nausea and GI side effects, trazodone for sleep, antipsychotics if really necessary for sleep and restlessness, as well as like, you know, psychosis that could be happening for folks withdrawing from alcohol, some like GI, the side effect medications, and then clonidine and tizanidine, which are like alpha agonists, which can be used to treat like the sweating, anxiety, and irritability that can come from opioid withdrawal specifically, but might also show up in like benzo and alcohol withdrawal. So just like listen to like what the patients are telling you they're experiencing. And again, most folks who like have a substance use disorder have been through withdrawal multiple times, and they know what kind of symptoms they're gonna feel, like even though each person's body is different. And of course, don't forget your good old pain meds, because people are just gonna be in pain. Unfortunately, there are also substances that I'm not going to talk about too much that we just don't have great medical treatments for at this moment. And there's like cutting edge research on this, but so far nothing that I am using in practice. So particularly stimulants, we still don't have a great treatment for, like methamphetamines and cocaine. And the important thing to know about these two is that like when you're withdrawing from stimulants, that can be like because stimulants are uppers. So when you're withdrawing, then you're like in a depressed state, and that can be confused with like opioid overdose, for example. And so like that's important to tease out the timeline between those two things, especially because a lot of patients are using both together. And then the only drug that like people talk about really for methamphetamine use, especially, is like mirtazapine, like 15 mgs QHS, but it's not really that effective. The data for it isn't good. It's just the only thing we have. And there is an up and coming research on contingency management programs in the outpatient setting, which is basically fancy name for like replacing the reward system that like a stimulant gives you in your brain with like an external reward system. And so that is like if you like essentially a patient tests like negative in their urine, like, you know, 3 weeks in a row or something, they get like a gift card, and that reward system is like replaced instead of like having the reward being the like, you know, the rush that you get from the drug. Other substances that we don't have great treatment for, like special K or ketamine, so like dissociative substances. And then there are all these like new fancy opioid mimics like xylazine, crocodile, and like kratom that people actually had been trying to use to get off of opioids, but unfortunately are also having like horrible effects. It's like crocodile, for example, like gives you like a terrible ulcer. Yeah, so all not great, and like really new and emerging drugs that like we just don't have. We're sort of trying to treat them the way we treat opioid use disorder, but it's really hard. So I'm just going to talk more about like the ones that we do have good treatments for, because these are the ones that like, you know, you should like expect to get to know, right? And expect to understand how to prescribe. So alcohol. Probably you all had to study like the timeline of alcohol withdrawal for boards. So I'm not going to go over that too much, but just know that like out of all the things that we treat, alcohol withdrawal is the thing that can kill you, right? Like withdrawal can lead to like seizures, delirium tremens, and like this is a case where like the more alcohol withdrawals you have, the worse it gets each time. And so it's really important to take a good history in somebody who's trying to get off of alcohol, because like if they have had a history of like having like hallucinations, for example, in the past with their withdrawals, then you may need them to be in a hospital monitored environment for them to get off of alcohol, because they could be at risk for seizures. And the treatment for alcohol withdrawal is different at different institutions. More and more of the country is leaning towards like a phenobarbital protocol. Some places are still going with a benzodiazepine protocol. So just be familiar with what your local clinic and hospital is used to doing. And then of course, like I don't have to talk about the negative outcomes of like alcohol use, right? We all know what that is. I will just talk about sort of what we have available in the outpatient setting to treat. So the best drugs that we have are naltrexone and gabapentin. Naltrexone being a medication that can be taken orally by day, like daily, or is now in an IM injectable monthly form, which is great for folks who have trouble keeping up with the daily medication. And the important thing about naltrexone is that you can be using it even while you're drinking, and even people who are drinking while on it will find that their drinking is reduced. And so that's really great. Gabapentin is useful not only as like a treatment for like the substance dependence, but also because it helps treat some of the symptoms, like I said earlier. All the other medications here are options, acamprosate, topiramate, but like are not shown to be as effective. And then disulfiram is the one that it famously like, you know, makes people like feel really, really gross if they drink alcohol. And you can see how that could be effective for some people, but for most people, it just like precludes them from taking the medication. So not to discount these, they are options if somebody is like, I want to try something, I've heard horrible things about naltrexone, or like, you know, they're on opioids for chronic pain, and so naltrexone is not a great option for them, but still important to know like naltrexone is our number one. And then alcohol, I think, is particularly a substance where like outpatient groups and intervention and therapy are like also a mainstay of treatment. I feel like for the other ones, like not so much, but alcohol particularly, like groups like AA and like sort of the non-religious like affiliated similar groups have been shown to have a really, really good track record in like keeping people from relapsing if that's what they want. Yeah, that's alcohol. Opioids. So opioids, withdrawal, unlike alcohol, will not kill you. The patient is gonna feel like they're gonna die, but like it will not kill you. They will just feel like shit. And so treating the withdrawal just depends on whether the patient is open to starting like medication-assisted therapy or not, right? Like, are they open to a prescribed opioid that is like a safer opioid to take because there's like a lower overdose like death like risk. That's basically it. That's why we do MAT, right? Is because the methadone and buprenorphine, which we have, is like has like a lower risk of somebody like dying from overdose. That's why it's a harm reduction strategy. If they are not willing to try one of those medications and start one of those medications, then like you're giving them the adjunct meds that I talked about before to help them get through it. Some people do want to just go cold turkey, which is really respectable and totally fine. The other thing that's really important to know is that if a patient is going through opioid withdrawal and they're in the hospital for something else, give them the fucking opioids. Like, give them the Dilaudid, give them the oxycodone. If that is what it takes for them to stay in the hospital for like IV antibiotics for the septic infection that's going to kill them, give it to them. Like you're not gonna like fix anything by like like forcing them to go through withdrawal unwillingly, and then they just leave AMA and then like die from their sepsis, right? So like, I think that's a really important thing to remember too. And then also give them Narcan if they're going to do that. If they're going to leave the hospital, any patient leaving you with an opioid use disorder, leaving the clinic, leaving the hospital, make sure they have Narcan on them. And then for methadone and bup, right? So methadone is the thing that we cannot prescribe as like family docs. Like this is not something you give in the clinic. This is something dispensed by a methadone clinic specifically outside. And often patients are having to go to those to get dosed every single day. They get urine drug testing every single day. So it's a really hard regimen to keep up, but methadone is also like has been, so in my gestalt is like the better medication for fentanyl right now because you can go up higher doses. And folks who are on fentanyl, like that is like a really potent drug. And buprenorphine typically has like sort of a ceiling effect, which is also why it's a safer medication. But it doesn't kind of like help folks enough when they're on high doses of fentanyl. Like they're still going to feel withdrawal from the max dose of buprenorphine that we can prescribe. So that's why methadone can be really helpful. So don't freak out if you see your patient on a dose of like 100 of fentanyl, 150, 200 of fentanyl, sorry, methadone, 100 of methadone, 150 of methadone. These are normal dosages, okay? Buprenorphine is what you can prescribe. And this is unfortunately the one that has the ceiling effect, but it does have an intramuscular formulation, long acting, that is also great, similar to naltrexone for alcohol if your patients would have a really hard time taking daily medications, or in the case of buprenorphine, 3 times a day, 4 times a day medications. And these are all like safe in pregnancy. That's really important to know too. So this is a quick slide on like how to help a patient start buprenorphine at home. I'm not going to talk about methadone because again, like we can't prescribe that, but this is what you can write out for a patient or print out for a patient. There are a lot of organizations with charts like these. I'm not going to go through them in detail, but essentially you want to time it so that because buprenorphine is a partial agonist, it will kick off some of the opioid that the patient is already taking. So if the patient is not already in withdrawal, the risk is like that it could precipitate withdrawal. And so you basically have to have a conversation with the patient of like how much they can put up with, like what they're willing to experience, and like what their own goals are to determine what kind of start is like the best start for them. These are some tips that Semi had written that I will just leave here because they are like safe usage tips. Like remember that like yelling at somebody to stop using something that they're addicted to is not going to help them, but telling them how they can be safer because most folks like do want to be safe. Like most folks do want to do their best for their health. It's just they're like compromised in their ability to like do that in the way that we understand it currently. So providing these types of tips and providing Narcan and resources as much as you can is also going to be a form of medicine. Okay. Yeah. Oh my God. All right. More things. So benzos, I will just say can also kill you because you can get seizures similar to alcohol. And that one we can sometimes do benzo tapers. A lot of times we don't. And you can give like an anti-seizure prophylaxis. And then tobacco, just know that varenicline is the most effective medication for tobacco cessation. But it is a long-term medication, and you want to kind of set patients up for success by starting at 1 to 2 weeks before you have them with a target quit date, and pair it with nicotine replacement therapy like a patch or a gum. Okay, now we're talking about MSK. And I think we're gonna go over, we're already going over, if that's okay. Thank you for everyone for sticking with us. Okay. MSK is not to fool anyone, not my favorite topic, and I don't think Ryan's favorite topic either. And so we're just gonna give you like a sort of rudimentary, like baseline understanding, like what we know. And if one of you is a future sports fellow and wants to join us for this boot camp in the future, please hit us up. When I think MSK, a patient comes into me with a musculoskeletal complaint, I think, what are the things that cause pain, right? Like, so what are the parts of the body actually that are causing pain? So this is what makes up your MSK system, right? Your bones, your muscle, the joint, which is made up of multiple things, like cartilage, ligaments, tendons, bursa, synovium, and nerves. And like basically all these things can either break, or they can get like these like chronic little micro injuries, which is what we call like a tendinopathy or a tendinitis. Or they can get inflamed or infected, right? And like that is these processes in combination with a specific part of the body is what causes pain. But really my question as a PCP when this comes up is like do I need to send them to ER, right? Like have they like ruptured their ACL or something? I need to send them to the ER. They have like a septic joint. Can I just send them to physical therapy? Is this like a chronic overuse injury that like they're overcompensating for in some way, or if I strengthen their musculature in some way, they'll get better? Is this something I need to send them to a specialist for, right? Like, do I need to send them to sports med, to physiatry, to ortho? And then like do I need to image it? Like, is my exam and like my gestalt for this patient and like what I understand about them good enough for me to like feel confident about my management, or do I need like a better picture of what's going on? And then the 3 key questions that I think about in my history is like the age of the patient, the location, obviously. And then is this an acute or likely traumatic sort of process, or is it a chronic process? And then just don't forget that like non-MSK things can like cause pain. And essentially like what I have been taught by like the sports fellowship director at my program is like, in a lot of cases, you should know the diagnosis before you even do your exam. And like all those like special provocative tests are just things that you do to confirm the diagnosis that you already know. And yeah, basically these are the core tenets of like treatment for any musculoskeletal complaint, like RICE, right? Like rest, ice, compression, elevation, physical therapy, pain medication for supportive care, because a lot of things will self-resolve, steroid injections or surgery. And then like newer stuff like PRP injections, therapeutic ultrasound, shockwave therapy that I will not be doing in the office. Maybe some of you will, who knows? And then the questions that I listed above. So an example of a differential where somebody's like history and sort of like the age and like the acuity really tells you what the differential is in the shoulder. So an older adult versus like a kid with an acute problem, like older adult is like much more likely to have a tear or some kind of impingement. Versus like a kid is more likely to have like a fracture or like a dislocation, because those bones are just like a little bit, those like bones are just a little bit weaker, right? They're a little bit bendy. And then like adults, again, like a chronic process, kids chronic process, adults, you're gonna get like arthritis, right? That's like an old person's disease, or like a frozen shoulder. Versus a kid is gonna get like apophysitis, which is sort of this like injury to the growth plate, versus like a malignancy. Bone malignancy is something we think about more in children. So this is just a way that your differential could be for like each part of the body. And I'm gonna turn over to Ryan.
Okay, I'm gonna try to wrap everything up in the next 5 minutes, so bear with me. Just gonna talk about physical exam briefly. The punchline is, like, if you were to just take one thing from this talk, is these 5 different areas for MSK exam. So inspection, palpation, range of motion, special tests, and imaging. And really, so what does this mean? Inspection, just looking at it, like how does it look? Palpation, touch the thing. Does it elicit pain in certain parts? Does it feel weird? Is there any like weird mass or bulging or crunching? Range of motion, can they move as expected for that joint? And then special tests, it really depends on where you're examining, and imaging if we need it. So palpation, basically main things are like, is there swelling? Is there deformity? Is the muscle there, or is it wasted? And you can look at these, the rest of this table on your own time. Range of motion, these are like expected degrees of motion. I'm gonna skip this because let's be real, who is carrying a protractor in clinic? And then special tests. So for example, many people know the special tests for the knee. So like Lockman's, anterior drawer, posterior drawer, McMurray's. And so these are different tests that tell you like, oh, if this is positive, then maybe you have this diagnosis. Each joint has its own special tests. I would recommend just going to whatever resource you use to study medical information, whether it be up to date or Dynamed or whatever, and then just typing in shoulder pain, and then it'll tell you special tests when you're seeing a patient in clinic. And for imaging, you can get a bunch of different things: X-ray, CT, MRI, ultrasound. They all have pros and cons. I'm going to skip this for now. Gender affirming care, the last topic of our talk. So these slides are from Dr. Wenzel, who presented this last year. The long story short for the initial visit is really trying to be as welcoming as possible, assessing the overall situation, and getting to know the patient. So there are many ways that we can make the clinical environment more hospitable, more accepting, more welcoming for everybody. I think that's even more important for people who identify as not cisgender. And in terms of criteria for starting gender affirming care, there needs to be a well-documented history of gender dysphoria. I won't go into it. However, gender dysphoria as a DSM-5 criteria is actually not anything like the definition that we use in common language. And so you can look that up on Google later. But the patient also needs to have capacity. So are they able to make an informed decision on their own? Are they, and then basically you have to document a significant medical concern. And these are a bunch of different things that you should ask your patients when they are coming to you for gender affirming care, because so many things we just don't know unless we ask explicitly. And so we really should not be assuming anything. These are the tests that we would take for the first visit before prescribing any sort of medication. On the left is for testosterone, on the right is for estrogen. These are the different ways to treat for estrogen. A bunch of different options: tablets, patches, gel, injectables. And then there are adjunct meds that we use to reduce testosterone production in response to taking exogenous estrogen. For testosterone, similarly, bunch of different routes: injectable, transdermal, implants. Testapels are really cool, brand new. You inject kind of implant them similar to an Nexplanon, and then they just dissolve. And then there's also oral, but we don't really use that. Monitoring every 3 months is typically what we do, both for estrogen and testosterone. And these are excellent resources that you can look up that all have very comprehensive information in terms of how to navigate gender-affirming care in the primary care setting. But yeah, that's about it. Thanks, everybody. I'll pass it to Katrina.
Thank you so much, Ryan and Leena and Suzanna and everyone else for being here and staying throughout the session. Yeah, thank you for all of this information. It's been super, super helpful. And just one last time, we'll post the feedback form in the chat if you guys can fill it out. It's really helpful for future sessions, but we appreciate everyone's time. Hope everyone has a great evening.